who did open Achilles tendon know that we have soft tissue problem, and this is not the worst one. This is the worst one, especially when you have a huge reconstruction and a vision surgery. Something happened like this, and then the plastic surgeon is your best friend. And if you look at this hind foot and Achilles, you never will have a good function. So the disadvantages of MIS are poor visualization of sensitive structures, nerve leads, poor identification of the pathology of the tendon. We want to see what we do, and no visual control of the surgical procedure. That's why I think we should do it endoscopically. What I'm doing now is acute rupture as controlling mid-portion tendinopathies, chronic ruptures, and defects, infect pathology. I do everything. Since 8 years I haven't opened an Achilles tendon. We have talked about the reason for mid-portion. Chris told us about the neovascularization in neonerves, and that was the procedure we did before. This was the conservative treatment by Akon Alfredson with the polydocanol. And this is my technique. I have an only medial approach. You see here the tendinopathy here, medial, then a little bit of making room for the scopes. You're sitting opposite to the tower, and that's what you're looking in. And then you see here the Achilles tendon, and you have to debride the complete soft tissue with the neovessels and neonerves. Then you debride the peritendinium and make some hemostasis. In cases where we have changes in the structure, we make the dissection. We shave the peritendinium, make a longitudinal splitting associated to the MRI. That's the video you see here. Here's the Achilles tendon. We go and debride everything, stays, and then we debride the peritendinium. Very smooth operation. In my hands, very fast. It takes me 15-20 minutes. Then the splitting in cases of degeneration. So after treatment, the endoscopy have really no pain, but because I want very few function, very early function, I make a partial weight bearing of 2 weeks. I think it's not only the eccentric stretching, we have to stretch the flexor muscle chain. We are a sedentary society. You see this exercise here, and that is extremely important because I'm always seeing a shortening of the flexor muscle chain. Aquajogging, biking, and return to competitive sports in between 6 to 9 months. This is a serious. Meanwhile, some patients more. I think I have meanwhile more than 200 patients. And you see, when we look at the Weiser score, this is a evaluated score, very nice results, and in function, satisfaction, and strength, these are very good results. Chronic rupture is a stretching of the tendon by degeneration. You see, you have no pulley on your plantar flexion. You cannot make a heel rise. So that is how it's looking like. You see the complete degeneration, and there we have a lengthening of the tendon from the degeneration. Also, Chris showed how aggressive we have to work on that the years before, tendon transfer and whatever. What I do now is a percutaneous debridement, and if we have a weakening of the tendon, we have to do a percutaneous suture. Also for shortening the tendon, because they have a dorsiflexion, which is much more than normal. When you look in, this is not a normal tendon. You see that looks completely different. And you have to debride radically everything what you see. Otherwise, you don't have a good sound healing. As we do a reconstruction by percutaneous sutures, then we can go very aggressively. You see that here. And then you see the vessels and centrochromic degeneration. You have to debride that completely. Another case. You see the partial rupture inside. When you open the peritendinium, you see the full pathology. When we go in here, and I always do a ACP. I stay for ACP because this study is only 1 year. Every study in the lab is showing that it's working. You see here now ACP, and then I cover the defect with fiber glue. So what we do need for healing is fibroblasts, and they have 10 to 100 times more than in normal tissue. Last case, you see, this is a more advanced technique. You cannot start with this and then do mid-portion tendinoplasty. This is sometimes not very easy to find the degeneration completely. You see, this is a big defect. That's why we have to protect that by fiber and glue, what I do, and of course by a good suture. You see how it looks like. Well, this is my double knot technique, so you can go more aggressively with this technique. I do plantar flexion, but not dorsiflexion, but they can do immediately plantar flexion even in those cases. This is a lasso loop technique, very simple, very easy. You have to protect a little bit the sural nerve. I do the incision about 1.5 to 2 centimeters, and I see the sural nerve, and then I have no problem that I suture the nerve and have nerve irritations. You see, one force, one back. This is nearly real time. It takes you 10 minutes when you are familiar with this technique. Okay, I have some other good. So the chronic ruptures, we have at this time more than 60 patients, and you see the chronic ruptures were not that good. Oh, sorry. No. There were only 87, and you see, I think this is reliable, only 8.2, 8.3 in the VAS score. They are very happy with it, but we have not a normal tendon again. We have a degenerated tendon and the reconstruction, so I think this is reliable. So in defect problems, the incidence of deep infection in bigger repairs is 18%, and minimal invasive using semi-tendinous preserves skin integrity, and we can use it for large gaps. So this is harvesting very easy from in prone position, like we learned from the ACL reconstruction group. Most important that we have to mobilize this in a long-standing gap here. We have to mobilize the distal and the proximal part that we have when we fix it, a unit again, which is working as a unit. Otherwise, it's only bridged. So that is a little bit critical, because when we come, sometimes we have several operations come too deep. You have the nerve, neurovascular bundle. So this is a really specialist surgery. What I also want is a biological protection, a protection from my tendon transfer, and that's why I do a PDS internal splint, and I do it through the calcaneus, because then I have the best pulling. This is the semi-T transfer. You know, debridement. This is nothing like a tendon. This is a scar tissue, which was 6 centimeters in this case. Again, the protection, I call it my internal fixator through the calcaneus, very good pulley, very stable, and then in plantar flexion, complete tightening in plantar flexion. I've never seen a deficit in both. And then my semi-T transfer to bring it up, and then I cross it from medial to lateral and from lateral to medial, and I fix it with sutures. So this is the final construct. You see the stress bypass by the. I have my own boot, and therapy boot, which is a plastic tongue. You cannot do dorsiflexion 2 centimeters of heel rise, and I put them for 8 to 10 weeks in my boot. We have more than 40 patients. Meanwhile, you see it's going lower, 71, because they have a long-standing, they have no muscles anymore when they come to me, and infection is something where you don't get 100%. You see 7.7 or 7.8, and there was only a minor infection after 4 months, and one dehiscence from non-resorbable suture. I take now resorbable suture. We did isokinetic measurements, and side-to-side difference of plantar flexion is comparable, and we are a little bit better than in the literature. And this is an infection 3 times sinus, open up, debrided first. After 2 weeks he came back, You see that I did the extremity transfer, and that is after 1 year. And remember this guy, he was a soccer player 3 times, 2 years he couldn't play soccer. And that's another case. You see the competence in soft tissue regeneration. You see a severe necrosis after a Achilles tendon surgery. Outside looks like this, and like this when I saw it. And I open it up and try to close a little bit. Then I make a lavage and ringer lactate and hydrogen, and then I put a vacuum on, and after time by time I couldn't close it. That was, it looks like after 8 weeks. Sorry. And that was after 4 months. And that is after 7 months. You see the knot of the... And you know, I don't need a plastic surgeon. As I told you, we are debrided, and then you go to the plastic surgeon, and then after 7 months, after 3 months, I did a transfer, and the skin was recovered. And I think we have good short-time results. And 5 years ago, it's in mid-portion. I think, like in the shoulder surgery, endoscopic assisted procedures must be considered in the future as the perspective, and the immediate post-operative pain relief and absence of post-operative complications led to a rapid post-operative recovery. And this is the guy who couldn't play 2.5 years soccer. I was a soccer professional. And this is not messy, but you can see how he's smiling and having back his soccer playing. Thank you. And if you want to learn it, you can read my book.